The surgical option for the Meckel's diverticulitis is Meckel's diverticulectomy. This is a diagrammatic representation which can be very helpful for you guys. So you can see here on your screen that this is the colon, and just close to the allocecal junction, this is the Meckel's diverticulum, which is present on the antimesenteric border. And this is the cecum actually, and this is the appendix, and just close to the ileum at the antimesenteric border there is Meckel's diverticulum. So the patient present to you with Meckel's diverticulitis and how you are going to perform diverticulectomy. The thing is this, that you have to, there are a few principles you have to follow in case of Meckel's diverticulectomy. Like you just, as you try to suture, or you try to clip or separate the base of the appendix, but in case of the Meckel's diverticulum, what you have to do is like simple you can do it with a linear stapler, or you can resect it. Just you have to get rid of the diverticulum at the base and at the broad base. Okay, so you can do it with the sutures, and you don't have to do it the way we do it for appendix, and you have to go for Meckelian diverticulectomy using the linear stapler. Or what else you can do, if there's a lot of portion, okay, so maybe possible that there's a perforation, and maybe possible that this segment of the gut is also involved, then you have to go for the limited gut resection. So in case of the limited gut resection, what you do is you can, if you have to think if there is a lot of sepsis, or a lot of free fluid and a lot of pus is being drained, then you don't have to go for a primary anastomosis. Maybe you do the ileostomy, and then later on after weeks you come on and you do the primary repair. But in case of simple cases, you can resect this part along with the Meckel's diverticulum, and you can go for end-to-end anastomosis. So that this is a resected Meckel diverticulum with ileum. So what happened, that there was a Meckel diverticulum. You can either do the diverticulectomy just by the use of a linear stapler, or by the use of sutures, or if there is extensive involvement of that particular segment of the gut is being involved, then you can go for limited resection and do primary end-to-end anastomosis. If there are no sepsis and there's a lot of pus and a lot of drainages involved, then you don't have to go for a primary repair. You just have to go for ileostomy. You have to wait, and then you have to follow your patient again after weeks, go for the secondary repair.